Okay, let's get this last portion complete. Some other issues that we need to look at in terms of withholding treatment or withdrawing treatment. Antibiotics. Antibiotics are treatments that can be withdrawn and withheld. 2 studies shows no difference in mortality between treated and untreated patients with pulmonary infections. 20 to 25% of pulmonary infections will be fatal regardless of treatment. Not saying you don't treat, but I'm saying it's a consideration. Terminal versus non-terminal. What is terminal? Terminal means you will die, but we are all going to die. So what is terminal? Well, some people think terminal is anybody who will die if they stop getting treatment. So that's true. That's true. Many people have conditions that if they don't take treatment, they will die. So is a diabetic terminal? Patient with type 1 diabetes, if they don't take their insulin, they will die, right? So are diabetics terminal? Think about it. Would you consider a diabetic patient to be terminal? By definition, they are. So what about a person who's on antipsychotic medications? Now, they probably won't die from their psychosis, but their condition puts them at higher risk for death. So are they terminal? Person who needs blood pressure medications to keep their blood pressure under 200 over 120. Terminal? Some questions there, aren't there? Would be ethical questions. Now, what about suicides, assisted suicides? What's the difference between killing and relief of suffering? Very hazy line. And this is a very common topic for those philosophy papers you'll be working on. What is the difference between relieving suffering and assisting suicide? Remember, we talked earlier about a person having unrelenting, unremitting pain and wanting more and more morphine, which can drive their respiratory rate down and hasten their death. So what are you doing? Are you relieving suffering, or are you assisting suicide? Or are you relieving suffering which results in assisting suicide? And where do you stop? At what point do you cross that line? I don't know. An ethical decision. We all know that sometimes aggressively treating pain will speed up the dying process. Or withholding medications will hasten the dying process. So how does that fall into it? If we're giving too much morphine and that speeds up the death process, even if they want the morphine, how is holding IV hydration that they want? They want you to hold the IV hydration. And so we disconnect the IV line. How is that any different? How is that different? Or is it different? So, in one regard, we're not going to give too much morphine because that'll slow their breathing and they'll die. And that's wrong. In another, we will disconnect their IV fluids because that's what they want, and they will die. I don't know. What do you think? What's your opinion? Because it is going to be just an opinion. An important opinion, but just an opinion. How about ageism? Ageism. that's the idea that the older a person gets, the more you're willing to maybe change your guidelines. Talk about that 6-month-old child. We did CPR for a long time on a child with a congenital heart defect. The dad had told us after the fact that he knew the child would never make 1 year old. But yet we did CPR for about an hour and a half. If the person had been 90 years old and their heart stopped, do you think we would have done CPR for an hour and a half? My guess is not. Is that justice? Are we treating people equally? Not on your life. Not at all. In neither situations, the 6-month-old or the 90-year-old, neither one were in a position to say, give me CPR or don't give me CPR. We chose for them. The 6-month-old, we worked a long time. The 90-year-old, we work a little bit and say, we're done. That's not justice. Age is a poor predictor of success or failure of treatment. Now, someone who is 75 to 90 years old, this is current research, if you're between the ages of 75 to 90, you have an average life expectancy of 12.4 more years, just say 12 years. So that means a 79-year-old will generally lives to 91. An 89-year-old patient has a life expectancy of 7.1 years. So if you make it to 89, you'll probably make it to 96. And if you're 99 years old, you're on average going to live another 3.5 years. So at what point is a person too old to vigorously treat? I don't know. But I do know that I know a lot of people who are 100 years old and still functioning. I took care of a person, I'm not going to get too specific, but this person was 100 years old. And he still held a job. He owned his own business. He still drove his own car. He still balanced his checkbooks, did his taxes, did his grocery shopping, cooked for himself. He's 100 years old. I would suggest that if his heart stopped, he's worth doing CPR on. And I know some people who are 70 years old who, if their heart stopped, it stopped. Age doesn't really mean anything. Advanced directives do not save money. People with advanced directives spend less in their last year of life because they tend to have predictable conditions. So a person who has cancer and an advanced directive will spend less in the last year because they know what's going to happen. Now, are there cost savings with advanced directives? Gunderson Lutheran out in La Crosse, probably out near where some of my students here are, they've been shown that advanced directives have been shown to decrease costs in the last 2 years of life and improve quality of care. Now, hospitals don't get paid for readmissions. Nursing homes get penalized for not recognizing and acting on changes in conditions. But when there's advanced directives, it kind of protects everybody. And it makes sure that everybody knows what is wanted, how aggressive a person needs to go. So make sure that everybody's fully informed. Start the conversation with your family, and then start and use that as practice. And then start bringing that conversation to the families of your patients. Make sure that everybody understands what could happen long term. This is nothing more than an educational need. The idea, everybody deserves a good death. And for some people, there is no such thing as a good death, that all deaths are bad, but sorry, everybody dies. The question is, do you want to die scrabbling for that last couple days? Or do you want your remaining days to be peaceful, relaxed, and calm? Hospice is a wonderful program for helping those last days be peaceful, painless, or reduce pain and calm. When a person chooses to go into hospice, they stop fighting death and they start the grieving process early. They change the focus on, the focus is changed from fighting death to bringing peace. More people need to understand what hospice is for. Hospice does not mean that the person is giving up. The hospice means the person is accepting the future. Now, there's a lot of warning signs on the trajectory of dying. When a person starts having repeated hospitalizations, a marked functional decline, they are starting to lose weight, not eating, difficulty swallowing, a progressive weight loss. These are signs that the person is shutting down. They're sleeping more, much more. Behavioral changes, cognitive changes. They start saying goodbye to people. They start saying, I think I'm dying. You need to start thinking, maybe it's time to have a real talk about what we're going to do next. Do we bring hospice in? Do we start talking to advanced directives? Hopefully that's already been talked about. Nursing home staff needs to document when these things start happening. When a person starts saying, I'm ready to go now, or when am I going, or this is taking so long, document that. That's really important to document because that's acknowledging the person's statements. It's acknowledging their fears and sometimes their relief. Sometimes people don't like the word hospice. It's scary. Palliative care is another way of saying it. Palliative care is nothing more than treating symptoms. You're no longer treating the condition, you're treating the symptoms. So, pain control. Maybe diuretics to help people breathe, but not necessarily for anything else. Oxygen, sure, but no codes. End of life, we need people to be calm, relaxed, pain-free. That's the biggest thing. Keep people calm, relaxed. Hospice nurses use a lot of morphine and lorazepam, and that's really good. Morphine helps air hunger in addition to pain. So if a person is having gasping breath, they'll give morphine. Not necessarily because of pain, but it relaxes those smooth muscles and makes air easier to get in. A person's having tremors that are painful, they'll give lorazepam. Not for anti-anxiety, but to just reduce those muscle spasms. The whole idea is to ease the person's anxiety, pain, suffering. That's it. We're not trying to prolong death, prolong life. We're not trying to speed death either. We're trying to make the person go to death as calm as possible. Now, we all know that opioids, morphine, classic, can cause respiratory sedation. That's right. It always can, but it doesn't very often. Opioids do three things first. The first thing is it takes pain away. So if a person's having pain and you give them morphine, the first thing is it takes pain. The second thing it'll do is it'll make them drowsy. So it causes sedation. And only then, and only after sedation has happened, will it potentially depress respiratory rates and vital signs. And some people may need a lot of morphine. They may need to get to the sedation effect before they have any pain relief. That's okay. If that's what they need, that's what they need. Respiratory depression is not a sudden or mysterious or uncontrollable effect. It progresses predictably. Pain control, sedation, respiratory effects. So when a person is sleeping, you stop giving them morphine. Right? So the whole fear of causing respiratory depression it's real, but not justified to be this big common, we got to watch for respiratory depression, because it really, you have to move through those steps. You know, if you give people morphine and they say the pain went from an 8 to a 4, they still have pain. They're talking, so they're not sedated. So respiratory depression, not going to happen yet. Morphine is excellent at, as I mentioned, relieving air hunger, because air hunger causes anxiety. So you give morphine, and that helps relax the smooth muscles of the airways, and you get more air in, and that causes decreased anxiety, which reduces everything. It's very good. There are delta receptors in the lungs, and that's what helps that morphine relax dyspnea. A lot of times people need 2.5 to 5 milligrams every 4 hours of morphine or more, sometimes much more, to get relief. There are people in end-stage cancers that may be getting 10s and 20s of milligrams of morphine an hour just for management of symptom control. There is no ceiling dose of morphine. Sometimes, some medications, Vicodin, let's go with Vicodin. If the person's getting 5 milligrams, 500s, 5 milligrams of Vicodin with 500 milligrams of Tylenol, what's the maximum they can have? 4,000 milligrams of Tylenol if they're under age 60, and then it's 3,200. So they can have at most 8 tablets of Vicodin a day, max. That's the ceiling dose. Any more than that, and you're going to have side effects that are unwanted. Morphine, there is no ceiling dose. You titrate it until there's relief. Now, assuming you have orders that say that, you just can't go give morphine at your own orders. However, depending upon where you work, your orders may give you a lot of leeway. I worked in a critical care unit one time, and the patient had excruciating, unremitting pain with air hunger and dyspnea. The doctor wrote this order: morphine, PRN. Morphine, PRN. I've been a nurse about 3 years at the time, so that kind of threw me off, and I went, "Doctor, do you want a time or do you want a quantity?" He goes, "No, you're a critical care nurse. Morphine as needed. You'll monitor them." And so that gave us the authority to give as little or as much as we needed for pain control, for air hunger, for anxiety, for dyspnea. When the symptoms were resolved, we stopped giving it. When they came back, we gave them more. When you're working a unit or with a doctor that has that level of trust in you as a nurse, it's a wonderful thing. It really is. And I hope that all of you at some point get to the level of confidence in yourself, and in a position where the doctors have that level of confidence in you, because that's when we can actually work at our best. the patient never stopped breathing, but they had good pain control. There's also medications you can give, corticosteroids to reduce inflammation, chlorpromazine to help with ventilation, scopolamine. It reduces secretions and also sedates. And you can give that in patches. That works really good long term to help dry a person out and reduce oral secretions. Oxygen. We can give oxygen. Sometimes just increasing air movements, putting a fan at the foot of the bed and blowing air in their face, sometimes that little bit of air movement just helps. Put them in a breathing position, high Fowler's maybe even. Avoid activity, avoid talking, reduce the lights, reduce stimulation. Whatever it takes to make the person comfortable. Because at that point, maybe that's as much as they can ask for. Anticipate changes. Anticipate that they're going to stop wanting to eat. Even if you give them their favorite foods, they're not going to want to eat. That's okay. You can offer it, but if they say no, they say no. They may stop drinking, or they may want one thing in particular. What are you going to do? Now the person is in palliative care, and they want to have a beer or a glass of wine. They don't want anything else. Maybe they want a sip of their favorite whiskey. What are you going to do? Going to give it to them? They're on morphine. Alcohol and morphine. A wicked combination, right? I hope that you're in a place that allows you the common sense to give them what they want. I know if I'm your patient and I ask for some of my favorite scotch, I hope you give it to me. Even if you have to dip a toothette and put it in my mouth so I can sip it. Not going to change the end result, is it? But how is it going to make me feel emotionally? How's it going to make me feel as a person? You have to start thinking big picture here. Remember, we're not trying to prolong life. We're trying to provide relief, try to provide comfort. And if that person says a little sip of wine, or that can of beer, or that sip of whiskey is what they need to be happy, give it to them. Obviously, if you're in a position where orders do not allow it, orders don't allow it. But what I hope you do then is you ask for orders. Ask for permission to give your patient what they want. Be your patient's advocate. Please advocate for your patient to make them happy. Give them what they want. Are they at risk for choking? So be it. Give them sips of something. Give them what they want, when they want it, as often as they want it. And if the orders don't allow for it, get those orders. We're on this earth a very limited time. At most, 100 years. In the grand scheme of everything, that's short. And when we're at the end, when we're in our last days and hours, if a person wants something, if they have the capacity to ask for it, find a way to give it. We're supposed to care for the whole person. Their whole body, their mind, their spirit. I'm a believer in giving them what they want. Always. Now, when they start developing a reduced level of consciousness, sleeping most of the time or all the time, they're not responding, they're not taking fluids anymore, the urine output is little and it's very concentrated, you know that things are ending. They're going to start getting progressive coldness at the extremities, moving toward the core. Start modeling, bottom of the body, or laying flat, so from the bottom of the tissue up. They start modeling. Blood's pooling. Start getting that rattling sound. They're going to start putting off a different odor. All signs that it's short. 48 hours maybe less, maybe more, but not long. That's okay. It's the expected. We need to be teaching the family that this is what we expect. Remember, we don't know when the person stops hearing, so it's okay to always talk to them. And if there's any family squabbling, that should be done outside the room because we don't know what they hear. Our goal is comfort for everybody. And you know what? This last section, you probably already knew all that, but it's really, really important. Now, what if we're in a situation where we think we're crossing over from reducing suffering over to assisting suicide? Almost every facility has an ethics committee. Go to it. Discuss what options are available. Find out who needs to make decisions. Find out if the decisions that are being made are appropriate. Have they been made in the past? If they've been made before, they're probably okay. If this is the first time, get more people on board. You want to have support for as many people as possible, so that down the road, when people second guess, that everyone is protected. All right, that's it for this lecture. It's been a long lecture. There'll be one more video explaining this week's discussion question. This week's discussion question is a little different, so I want to make sure we all understand it. Thanks for listening this long. I hope you're able to take good notes. And as always, Fridays, 9 till 11, I'll be in the online chat room. This was a complicated lecture. It's a very important lecture. Don't be afraid to ask me questions. And we'll talk to you later.